Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from the Philippines, Professor Lourdes Lucena. Professor Lucena is a faculty at the Bicol University College of Medicine, Philippines. She is the chair of the Neurotrauma Committee of the Asia-Australasia Society of Neurological Surgeons, and she was the previous chair of the Philippines Specialty Board of Neurosurgery and previous secretary of the Board of Directors of the Academy of Filipino Neurosurgeons. She is a strong proponent for women in neurosurgery in the world, and she is a noted speaker at various international conferences and workshops. She is a noted author who has published several articles in various peer-reviewed journals. We are extremely honored to have her today at our webinars, and today she will be talking about recent advances in neurotrauma. The speaker for the second session of today is our honored guest from China, Professor Eugene Liao. Dr. Liao got his medical degree at the Shanghai Medical University in 2008 and finished neurosurgery resident training in Huashan Hospital, Fudan University. He is now attending staff at the neurosurgery department of the Huashan Hospital. He is also a hybrid neurosurgeon and is a specialist in treatment of Moyamoya and complex cerebrovascular aneurysms. He performs over 300 neurovascular operations annually. We are extremely honored to have him today at webinars, and today we'll be talking about blood pressure measurement in cortical branches in Moyamoya disease. The chair for the first session of today's webinar is our honored guest from the USA, Professor Andrew Reisner. Professor Reisner is the Elaine and John C. Carlos Chair for Neurotrauma for Pediatric Neurosurgery at the Children's Healthcare of Atlanta, Emory University School of Medicine, USA. He is the chair for Neurotraumatology Division of the WFNS. His research interests include traumatic brain injury, brain tumors, radiosurgery, and intracranial bleeds in children. He is a noted author with several publications in various peer journals, and he is an invited faculty to workshops and conferences worldwide. Decorated with the Children's Care Network Award of Merit for significant contribution to pediatrics in 2020. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from China, Professor Shubin. Professor Shubin is the professor of neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He is also the vice president of the ACNS. He is a specialist in Moyamoya disease and currently holds the largest number of cases for bypass for the same. He is a strong proponent of online neurosurgical education and is the cornerstone of our webinars ever since its inception. He is a noted speaker at conferences and workshops all over the world, and he is also a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Andrew Reisner.
Before I introduce our first guest lecturer, I'd like to thank you, Dr. Raja, as well as Dr. Kato and the ACNS. I deal with many organizations as through the WFNS, and I cannot think of one that is more organized, hospitable, professional than you and your educational committee. And I'd like to thank both of you for inviting me, for organizing these wonderful webinars, and having me here today. That said, it is such an honor and a pleasure to introduce somebody who I'm getting to know, Lynn Lord Lucena. She is, I was going to say, a giant in neurotrauma. That would be true, but that would be incomplete. She's a giant in women's neurosurgery, in global neurosurgery, and I have no doubt many, many other fields in neurosurgery as well. Preparing for this quick introduction, I looked at her CV, and really, I just got to wonder out aloud, I wonder if she has a clone. She has been so active in so many things that it's hard to believe it's just one person, and I wouldn't be surprised if there's an identical twin out there who's helping her with everything. She did her training in superb institutions, received a medical degree in 1991, then proceeded to general surgery and neurosurgery, and no surprise to anybody, least of all myself, won a number of awards along the way, including the Outstanding Intern Award, the Golden Scalpel Award, and as her career has progressed, the awards have just flown in and rolled on in. If I could just mention one or two, she was the international awardee in 2016 for a woman in neurosurgery visiting International Surgeon Award. She has won the International Scholarship Grant from the WFNS and the Turkish Neurosurgical Society. And again, no surprise here, she won the Leadership Journey Exemplar Award for her invaluable contributions, leading not only neurosurgery, but medicine as well. Lynn is a dedicated teacher. She's dedicated to advancing our craft, which is evident by her numerous presentations and publications. But perhaps is most striking to me is the leadership roles that she's had. I think she has had just about held every position in a number of prestigious organizations, including the Academy of Filipino Neurosurgeons, the AASNS, the Women in Neurosurgery, the WFNS and WHO committee. Although we've never met in person, I've heard that Lynn not only works hard, but plays hard too. And at the risk of embarrassing you, Lynn, I am going to show a picture sent to you by our common friend, Laura Lipper from Italy. And I'm not too sure it projects well, but there she is at, I believe, a WHO conference in Geneva, if I'm not mistaken, with a couple of my good friends, Laura Lipper, Ernst Bartholomew, and others, and of course, Roxana Garcia. So not only does Lynn work hard, but she plays hard. She's also known for giving out treats. If I'm not mistaken, Lynn, it's special marzipan treats. So even though today we are not going to get any gastronomic treats, I have no doubt we'll be getting intellectual and inspirational treats from Professor Lucina. Over to you, Lynn. Thank you.
Thank you so much, Professor Andrew, for that very kind introduction. And you made me recall such fun times that we had in Geneva when we attended the World Health Organization as part of the collaboration between the WFNS and the WHO in several protocols, and especially just to mention one, the folate fortification to prevent spina bifida. Okay, so and also let me just thank again the ASEAN Congress of Neurological Surgeons, Professor Raja, and of course my friend Professor Yoko Kato. We go back. I've known her since I was a resident in the Philippine General Hospital. She is one of my idols in neurosurgery. If I would see it, if I could say so, like when I met her, I said, "Well, she's really one of those who had blazed lots of trails, not just, of course, as a lady in neurosurgery in Japan and also worldwide." So I would like to thank her and also all the organizers of the ASEAN Congress, and of course you, Professor Andrew. And I've met Professor Shubin at some point when I spoke at one of the webinars again in ACNS also, and of course Professor Bunseng Lu, and I've met you at some point, but the others I haven't met, and I would like to thank them for being here and listening to my talk. So maybe without much further ado, I'd like to start and share my screen. Again, thank you for this very well organized ACNS webinars, which I have been taking a look ever since COVID started. So the objectives for this talk is to discuss the current trends and researches in neurotrauma, mainly the management of increased intracranial pressure due to traumatic brain injury. I will touch more also on the Brain Trauma Foundation guidelines with the severe TBI, and to discuss a present and present a stepwise algorithm-based approach in traumatic brain injury management. So we all know that severe traumatic brain injury is a brain injury that results in loss of consciousness of greater than 6 hours and a GCS of 3 to 8. Okay, so let me just say that neurosurgery has evolved in so many ways, so many advances, but it seems that neurotrauma has lagged behind, for several decades, even in the last 10 years. It's only, I think, recently that people are noticing already. And of course, we have the 2016 Brain Trauma Foundation guidelines. And but there's a commensurate increase in brain trauma, in neurotrauma, precisely secondary to motor vehicle accidents. And it's being termed actually as a silent epidemic. So with this, we hope that the fourth edition of the 2016 Brain Trauma Foundation guidelines, later on, there will be updates. Actually, I am part of a group that is talking about crafting Brain Trauma Foundation. Professor Andrew knows about it, for low to middle income countries, like low resource areas. So hopefully we will come up with that in the next years. Okay. So again, let me just mention that the 2016, the Brain Trauma Foundation guidelines is not really a complete clinical protocol. It's a living guidelines model. So meaning it will evolve somehow in the next years. Okay. So, but it includes a lot of publications and meta-analysis. But the underlying goal here is to establish an evidence-based protocol that can be adapted into daily hospital management to minimize secondary injury, which we know will be disastrous to patients with brain trauma. Okay, so recommendations are reported as levels 1, 2, and 3. So let me emphasize this again. Level 1, steroids is not recommended for improving outcome or reducing ICP. So in patients with severe traumatic brain injury, high-dose methylprednisolone is actually associated with increased mortality and is contraindicated. But let me just mention that I still get some patients with traumatic brain injury coming in from far-flung areas being brought to me with dexamethasone incorporated in the list of medications. So again, I just hope that these kinds of webinar will reach widely so that it will be known that this is level 1 evidence. Okay, this is not only level 1 evidence actually here. So again, so now we go to level 2B evidence, which is the hyperosmolar therapy, in which Manitol is effective control of reached intracranial pressure at doses of 0.25 to 1 gram per kilo body weight. So we have to restrict Manitol use prior to ICP monitoring to patients with signs of transtentorial herniation or progressive neurologic deterioration, not attributable to extracranial causes, meaning neurologic deterioration, not secondary to possible blood loss with deterioration of sensorium secondary to decreasing blood pressure. So let me just take a look at the third edition of the Brain Trauma Foundation guidelines. These are the ones that have been included. Okay, so how does it differ from the 2016 or the fourth edition? So they have actually included several. Okay, so these are the things that were included. So they have included here the compressive craniectomy, hypothermia, and cerebrospinal fluid drainage. Okay, so we will go through some of this as we go along in the lecture. Okay, so level 2A, let us discuss now the compressive craniectomy. So based on the guidelines, the bifrontal discompressive craniectomy is not recommended to improve outcomes as measured by the Glasgow Outcome Score at 6 months post-injury in severe traumatic brain injury patients with diffuse injury, meaning no mass lesions, and with intracranial pressure elevation to values of more than 20 millimeters mercury for more than 15 minutes within a 1 hour period that are refractory to first-tier therapies. We will go through the tier therapies later on in the algorithm-based management. Okay, so, but again, meaning it does not really improve the outcomes, but this is recommended, or this procedure can be has been demonstrated actually to reduce intracranial pressure and to minimize days in the ICU. So also a large frontotemporoparietal decompressive craniectomy, not less than 12 by 15 centimeters or 15 centimeters diameter, is recommended over a small frontotemporoparietal decompressive craniectomy to reduce mortality and improve neurologic outcomes in patients with severe traumatic brain injury. So the results of the rescue ICP trial was actually released after these guidelines have been completed. So let me just take a look at present to you the comparison between rescue ICP trial and DECRA. Okay, these both address decompressive craniectomy for severe traumatic brain injury. In rescue ICP, decompressive craniectomy came as the last tier treatment. But in DECRA, it was an early treatment or on the second tier. Procedure in rescue ICP was a unilateral, hemispheric, and bifrontal craniectomy. This is the things that they evaluated. But here in DECRA was only bifrontal craniectomy. So patients with intracranial hematoma were included here in rescue, but in DECRA it was excluded. So what were the results? Based on this RCT in rescue, they saw that there was improved outcome with the compressive craniectomy for the surgical group versus DECRA, which had a poorer outcome. Okay, so level 2A, infection prophylaxis. They also recommended that early tracheostomy can be done to reduce your mechanical ventilation days when overall benefit outweigh complications with such a procedure. But this does not reduce mortality or rate of nosocomial pneumonia. Level 2A, seizure prophylaxis. So they recommended the use of phenytoin or valproate to decrease the incidence early post-traumatic seizures, but it does not prevent late post-traumatic seizures. So early post-traumatic seizures within 7 days of injury, if the overall benefit outweigh the complications. But early post-traumatic seizures were not associated with worse outcomes. And there is actually insufficient evidence to recommend levetiracetam as of now compared to phenytoin regarding efficacy in preventing early post-traumatic seizures and toxicity. I think these statements will be somehow need some updating later on in years to come, because I see a lot of patients being given levetiracetam here in our areas. Okay, so. And level 2A, nutrition, feeding patients to attain basal caloric replacement at least by the 5th day. This is very important. Somehow the residents or the trainees, they somehow forget that the early feeding is very important in order to decrease mortality. Okay. And level 2B, if transgastric jejunal feeding can be done, this can actually reduce incidence of ventilator-associated pneumonia. So with prophylactic hypothermia, this is a level 2B evidence. So if it is early, within 2.5 hours, or short term, 48 hours until 48 hours post-injury, prophylactic hypothermia is not recommended to improve outcomes in patients with diffuse injury. Okay. So ICP monitoring is level 2B evidence. It says here that managing severe TBI patients using the ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. Okay, so take note that in hospital and 2-week post-injury mortality. So with the Brain Trauma Foundation, it says here the cerebral perfusion pressure needs of 50 to 70 millimeters mercury should be the amount of pressure needed to maintain blood flow to the brain. And when you have your mean arterial pressure, this is the driving force that pushes blood to the brain. And of course, the intracranial pressure is the force that keeps the blood out, especially if this is increased. So when you have your formula of cerebral perfusion pressure is equal to the MAP minus ICP. For example, you have this blood pressure, 130/73, and ICP reads at 14. So you can calculate your mean arterial pressure, and you will be able to come up with your cerebral perfusion pressure. So you can actually compute if the blood flow to your brain is adequate. Which means if it's adequate, most probably your oxygenation would also be adequate. So with the intracranial pressure monitoring, recommendations from the prior third edition was not supported by evidence meeting the current standards. So, but the ICP, they said, should be monitored in all salvageable patients with a traumatic brain injury, GCS 3 to 8, after resuscitation, and an abnormal CT scan. What is an abnormal CT scan? It should something that reveals hematomas, contusion, swelling, herniation, or compressed basal cisterns. It is also indicated in patients with severe TBI with a normal scan if more than or equal to 2 of the following features are noted at admission. Patient is more than 40 years of age, there is unilateral or bilateral motor posturing, or the systolic blood pressure is more than 90 millimeters mercury. So again, level 2B evidence, you can treat your intracranial pressure if it goes higher than 22 millimeters mercury. It is recommended because values above this are associated with increased mortality. So level 3 is that a combination of ICP values and clinical and brain CT findings may be used to make management decisions. So this is the benchmark evidence from the BEST TRIP trial in South America. So this was a randomized controlled multi-center trial with the primary objective to determine whether the information derived from the monitoring of intracranial pressure in patients with severe TBI will improve medical practice and patient outcomes. So I'm cutting it to the conclusion in which it says that for patients with severe traumatic brain injury, care focused on maintaining monitored intracranial pressure at 20 millimeters mercury or less was not shown to be superior to care based or on imaging and clinical examination. So meaning they did not find much evidence to support that putting in an ICP was much better with just the care based on imaging and clinical examination. However, there was a consensus-based interpretation of the benchmark or BEST TRIP trial in the Journal of Neurotrauma in November 2015. It says there that, of course, the BEST TRIP trial studied protocols, not the ICP monitoring per se. And it applied only to these protocols and specific study groups and should not be generalized to other treatment approaches or patient groups. And of course, it strongly calls for the recommended further research on ICP interpretation and use and should be applied cautiously to regions with much different treatment milieu. It also did not investigate the utility of treating monitored ICP in the specific patient group with already established intracranial hypertension. And it should not change the practice of those already very much using the currently in their monitoring ICP monitors. And also it's provided a protocol used in non-monitored study patients that should be considered when treating without ICP monitoring. So see, there's a lot of ICP monitors now in the market that can be used. So you have different kinds. You have your intraventricular, you have your subdural, and all this could be useful for armamentarium for your patients, okay? And I saw here as the guidance for the management of severe TBI, especially with those 20 to 25 millimeters mercury from Leroux, in that invasive ICP monitor is not recommended in comatose patients with initial normal CT scan, especially obtained early in injury. However, it is indicated if the CT scan shows brain swelling and compression of cisterns. It is also can be considered in patients with large bifrontal contusions independent of neurological condition. And again, it is recommended if your neuro exam is unreliable in patients with decompressive craniectomy for intracranial hypertension. Okay, so let me go now again to what we have been using or with what we have been doing ever since, I'm immemorial, I guess. So osmotic therapy, there is no level 1 evidence as of until now. Okay, so we all use Manitol. It's an osmotic agent and diuresis. However, you have your side effects like acute renal failure, hyperkalemia, hypotension, and rebound increments in ICP. We all know that you can use it at 0.25 to 1 gram per kilo of body weight. Okay, so but again, let me emphasize, there's no level 1 evidence for us using this Manitol. Okay. We all know that it produces osmotic diuresis, and however, the exact mode of action in how it reduces your ICP is really less clear. But it has been thought about that Manitol reduces your intracranial pressure by reducing blood viscosity, which transiently increases your cerebral blood flow and oxygen transport and constricts your PL arterioles. This, in turn, decreases your cerebral blood volume and intracranial pressure. So, but studies have shown, but still, there's a theoretical concern with Manitol in that it can leak into brain tissue in patients with disrupted blood-brain barrier and could actually reverse your osmotic gradient and can give you rebound cerebral edema. We all know actually about osmos, okay? On the other hand, this has also been used, hypertonic saline, if the patient is already tolerant to Manitol. In recent studies, this has been a primary measure to control ICP. And sodium chloride has a reflection coefficient of 1, meaning this is actually the reflection coefficient of Manitol 0.9, hypertonic saline is 1, meaning it is more effective in excluding solutes from passing through the blood-brain barrier. So it has also been touted to normalize your resting membrane potential and normalize your normal intracellular electrolyte balance. So general guidelines, clinical guidelines. So Manitol, there's an added benefit if there is intravascular volume overload. The goal is actually in managing TBI is euvolemic intravascular volume. Renal insufficiency can increase, however, with supranormal serum sodium, but there is no ceiling yet to osmotic therapy limits. And your hypertonic saline can actually increase your mean arterial pressure, thereby having more benefit in improving your cerebral perfusion pressure. So, going back to hypertonic saline, this is an effective hyperosmolar agent for the control of ICP. It has been said to have theoretical advantages like hypovolemia and volume depletion does not occur with hypertonic saline. So it says that it's more safe to use this in trauma patients, especially those patients who are ongoing blood loss or depleted volume, okay, and hypotension. Use in wide range of concentrations from 3% to a continuous infusion to 23.4%. To intermittent boluses. Okay, so again, I said 1, reflection coefficient, so it's less likely to leak into the brain tissue. However, potential side effects is pulmonary edema, circulatory overload, increased chloride burden, and can also produce metabolic acidosis. So there has been multiple observation studies, small RCTs, meta-analysis, systematic reviews to compare the two. However, there is no compelling evidence to say which is better or really more superior. And majority of studies, though, would suggest that improving ICP control with hypertonic saline, along with possible improvements in cerebral perfusion brain tissue oxygenation, has been seen. So, like this study in 2009, which is a prospective non-randomized crossover study, they had patients with 42 episodes of intracranial hypertension. They received Manitol as first line of treatment, and you have hypertonic saline as a repeated episode of intracranial hypertension. It says here that both were associated with significant ICP reduction. However, hypertonic saline treatment was associated with lower ICP and higher cerebral perfusion than Manitol. Okay, so in comparison with Manitol also, it says here that hypertonic saline was associated with lower intracranial pressure, higher cerebral, again, CPP, and cardiac output. But it also concluded that when given a second-tier therapy for elevated intracranial pressure, which we will see later on in the ENLS, hypertonic saline is also associated with a significant improvement in your brain oxygen, cerebral perfusion pressure, and cardiac output in patients with severe TBI and intracranial hypertension, which was refractory to the previous Manitol administration. Okay, so comparing also smaller doses of Manitol and hypertonic saline on the effect of cerebral blood flow and metabolism in TBI. Okay, so this was a prospective randomized controlled trial. And again, they said both were effective in reducing ICP, but the smaller agents increased cerebral blood flow was greater in hypertonic saline group. There was no difference, however, in the neurologic outcome at 6 months using the Glasgow Outcome Score. Another study comparing both, this was a prospective trial which compared the similar osmotic loads given in patients with TBI. Okay, the mean reduction of ICP in Manitol was 7.96, and for hypertonic saline was 8.43. Okay, so they compared the duration of the effect for Manitol and hypertonic saline. And they found out that there was no statistically significant difference in either the reduction or the duration of decrease in your ICP that was observed. Okay, so they said it was both equally effective. Okay, so again here, let us take a look back at how you can stepwise management of elevated intracranial pressure in patients with severe TBI. Okay, so tier 0, this is actually a sort of a checklist. So tier 0, your standard measures, you need to intubate the patient and hook to mechanical ventilation. You have to go through all of this. Okay, so head of bed elevation, temperature control, and of course your oxidation and carbon dioxide. Yung tier 1 will be already the initial treatment of elevated intracranial pressure. You can have analgesia and propofol infusion, or you can actually have drainage of CSF from external ventricular drainage. Sorry. So here, it says here that on tier 1, you can have hypertonic saline or Manitol. Tier 2, if still elevated ICP despite initial therapy, you can have increase the treatment of hypertonic saline, or you can already sedate the patient. But again, your goal should be to increase your cerebral perfusion pressure to more than 70. Tier 3, if there's already refractory elevated intracranial pressure, you can repeat the CT scan to identify if there is a surgically correctable pathology, or you can resort to decompressive craniectomy. Other alternatives, which I will mention later, is barbiturate coma or therapeutic hypothermia. Sorry. Okay, so let me go back to the updated treatment recommendations. With cerebrospinal fluid drainage, level 3 evidence. It says here that the use of cerebrospinal fluid drainage to lower ICP in patients with an initial GCS of less than 6 during the first 12 hours after injury may be considered. It also be an EVD can also be considered to lower your ICP burden more effectively than intermittent use, continuous drainage, okay? So, taking a look at all these guidelines, we really need to consider again from the basic. So, the goal is to be able to control all this, okay? Hypothermia, hypoxia, and hypotension. Because these three specific endpoints are independent predictors of poor outcome in the pre-hospital and even in the emergency room department setting. So prevention of secondary injury is very important in treating your neurotrauma patients. So going now from the Brain Trauma Foundation guidelines, we now go to the tier-based, what we call emergency neurologic life support. So while we have the basic life support, we have the ATLS, ACLS, we also have the ENLS, okay, which has been an initiative and published in Neurocritical Care Journal in 2012. Okay, so this is managing series of protocols that describe key steps in managing patients in a neurologic emergency. Okay, so here we see management of traumatic brain injury and even traumatic spine injury. So there are other entities which we can manage with the emergency neurologic life support, like ischemic stroke, intracerebral hemorrhage, status epilepticus, subarachnoid hemorrhage, meningitis, and encephalitis, and of course, the practice of airway ventilation sedation. So they say that with this NLS, they emphasize intracranial hypertension and cerebral herniation are brain codes, which means these are the life-threatening neurological emergencies, something like you have a code in your cardiac or heart attack, okay? So signifying that intracranial compliance and adaptive mechanisms have been already overwhelmed. So with this, okay, so when you have your intracranial hypertension or herniation, so you go through your tier based algorithm. Okay, so this is basically we will go through this one by one in the next few slides. Okay, so with tier 0, you can have your brain code resuscitation. Again, the emphasis on the very basic, which means the ABC. So again, airway patency, ventilation, adequate circulation. So the goal here is to achieve euvolemia. So you can give 1 liter of normal saline, okay, prior to instituting your osmotic therapy. So only isohyperosmolar fluid should be used. Okay, so tier 0 still, you need, as I mentioned earlier in another slide, to facilitate your cerebral venous drainage, elevation of your head of bed 30 degrees, control hyperthermia, hyponatremia, agitation, which can actually increase your intracranial pressure. And here it's mentioned high-dose steroids, of course, if you have tumors, abscesses, and non-infectious neuroinflammatory conditions, but not traumatic brain injury. So tier 1, after instituting all those measures, you now go to your first level of to control your ICP. You have your Manitol, as I mentioned, and you can hyperventilate only as a temporizing measure, brief course, less than 2 hours. You want to achieve PaCO2 of 28 to 35 millimeters mercury. And you can have CSF drainage in patients with hydrocephalus. So you need to check also your sodium, maintain it between 140 to 150. So tier 1, what are the goals? You want to reverse the signs of brain herniation, okay? The clinical signs. And also you want to rapidly control your intracranial hypertension to reduce, again, as I have said, secondary injury. So you want to have an ICP and CPP targeted treatment. So you want to control your ICP elevations more than 20 millimeters mercury. You want to minimize that. And you want to maintain your cerebral perfusion pressure with a goal of more than 60 millimeters mercury. Okay, so going back, okay, so we have already the tier 1. Okay, so if this does not succeed in controlling your ICP, still you have your clinical signs of herniation, does not resolve. So within the first 2 hours, you need to return to ICP pre-treatment value, okay, and reevaluate whether you have missed something. And you can see that there may be adverse effects barring continuation of osmotic agents like renal failure, congestive heart failure, severe hypernatremia, and poor Manitol clearance based on osmotic gap. Okay, so with this transition from your first tier to your second tier criteria, you need to consider now repeating your CT scan because you can already have expanding hematoma, which is leading now to your uncontrolled intracranial pressure. And also, again, delayed post-traumatic lesions, particularly for ultra-early CT scans. So you have also to identify and correct coagulopathies. It's very important. So you need to check already, you should already have your blood parameters, bleeding parameters. And you need now to take a look if, based on your repeat scan, if you have surgical decompressive options. Okay. So tier 2 therapy, you have your hypertonic saline. See, it says here that based on this ENLS, hypertonic saline is on tier 2. So meaning if your patient has been given Manitol and there's still not effective to control your ICP. So you can give it, as I mentioned, from a ratio of 2 to 23.4%. And it is actually recommended if you are already using high dose and also infusion, not just bolus, you have to get a central line. Okay. So this is also indicated if your patient is hypotensive. And you can have 1 to 2 ml per kilo drip. So as I mentioned, via central venous catheter. So your target sodium level is 140 to 150. If you go higher than 150, you need to check it and maybe have to stop hypertonic saline infusion or giving it as a bolus. So you could consider also the use of propofol. So you need to have your friendly anesthesiologist by your side already to help you with this administration of this, or your neurocrit care. This patient should already be basically in the ICU. Okay, so also from tier 2 to tier 3, what is the criteria that should make you see that it's not working? Okay, so if you have failed to reduce your ICP by 25% of your pre-treatment value, and again, you have persistent ICP elevation of more than 20 to 25 millimeters mercury. So now you consider going into your tier 3 therapy, which is your metabolic suppression therapy via your barbiturates, which is actually able to reduce the metabolic demand of your cerebral blood flow. It reduces your cerebral blood flow and your intracranial pressure. So you can have a loading dose of thiopentol of 10 milligrams per kilo over 30 minutes, followed by 5 milligrams per kilo for 3 hours, followed by maintenance infusion of 1 milligram per kilo per hour. Okay, so if complete, then your ICP goes back to less than 20, you can return to your first tier. However, if this is incomplete and your ICP is more than 25%, it's not really going down, but still more than 20, you can have your infusion and you can actually adjust the dose. So monitoring also your EEG. So what are the adverse effects? You can have systemic hypotension, you can have severe infection, respiratory complications, and renal and hepatic dysfunction. So also on tier 3 therapy, you have your hypothermia, meaning you can reduce actually your metabolic demand, reduce your cerebral blood flow and ICP, and reduce the release of excitatory neurotransmitters. Target temperature is 30 to 34 degrees Celsius using surface or endovascular cooling methods. And you need to cool patients from 24 to 72 hours, followed by passive rewarming over 12 to 24 hours. So what are the adverse effects? Shivering, sepsis, hypotension, electrolyte abnormalities. So in tier 3, criteria of failure is that, again, you reduce, if you fail to reduce your ICP by 25% of the pre-treatment value, and you have your persistent ICP elevation even with barbiturates, and persistent ICP elevation even during induced hypothermia. So I have gone through the recent advances and the tier-based algorithm. So was I ahead of my time? Again, thank you for your kind attention. If you have questions, you may email me.
Thank Professor Lucina for a unbelievably comprehensive review of the recent literature. You've taken out the kernels and shared it with us. And my take-home message, and I'm sure yours, is we certainly have a lot more work to do. There are so many unknowns that are just so basic. And I thank you for highlighting that and your wonderful review.
We had indeed a very extensive and elaborate lecture from Professor Lucina, and she has showed us in detail about all the recent guidelines. If there are any questions, Dr. Liu would like to ask something.
Yeah. Thanks for bringing us back to the 4th edition of the traumatic brain injury guideline, which like Prof. Andrew have said, there's many much to be improvised because so far, even with that guideline, we don't see much improvement in terms of the outcome of the patient treated, especially among those with severe traumatic brain injury. I have 3 questions for you, Professor. First is, as you mentioned that tracheostomy would not reduce the risk of pneumonia, but we do practice regularly, especially those with severe traumatic brain injury. Those we don't foresee that we are able to extubate them. So in my country, previously, we used to do a so-called 3-in-1 procedure, especially those with surgical lesion. Why we call it 3-in-1 one is craniotomy for the surgical lesion, one is EVD, another one is tracheostomy. Simply because at time we don't have widely accessibility of the percutaneous tracheostomy, and we want to reduce the use of OT, and it's better for the patient to be weaned off faster from the OT. I want to know your opinion whether such practice is good in your experience as trauma surgeon. My second question, Professor, in many countries, and we found that now the EVD catheter becoming more and more expensive. Not talking about Spiegelberg, those are super expensive. We are talking about normal CSF drainage ventriculostomy type of ICP monitoring. And we are looking for those where we can replace the ICP with serious CT scan. And in our opinion, those with diffuse brain injury, especially grade 1 and grade 2, usually associated with almost normal ICP, which we can also treat them by regular CT scan rather than ICP monitoring, especially those with motor score of M5 do not have abnormal motor posturing. So what would you think that would be a good option for those, especially countries that cannot afford very expensive ICP catheter for the monitoring? My third question, I'm happy to see that you're talking about a CSF drainage and no over drainage are recommended. And I always tell my colleague that if the ICP is not more than 20, we should not drain the CSF, because I find that the brain needs protection by the CSF. The buoyancy and microgravity support for the brain is very, very important. That's why till now I still not very supportive of cystinostomy, where you mainly drain the CSF from the base of the skull, which you lost the effect of the CSF. It's more safer to drain CSF from the ventricle, which do not have much of microgravity support in brain. So what's your opinion regarding this 3 questions? Thank you, Professor.
Thank you so much, Professor Bunseng Du, and for those questions. First of all, I agree with you. For example, the patients come in and you already see that a decompressive craniectomy or a craniotomy is warranted, and the patient falls in the severe traumatic brain injury GCS. We also do commensurate tracheostomy already. So it's us not really 3-in-1, it's more of 2-in-1. So we do the craniotomy or craniectomy and the tracheostomy in one sitting. So that actually saves time. And again, I have found out that it reduces the time of the patient being in the mechanical ventilator. Okay, so I agree with that. But the EVD, again, because of financial constraints, that is also a very important consideration here, especially in the ICP monitor. So, but if a patient actually needs and has dilated ventricles, possible hydrocephalus for a cerebellar hematoma, we put in an EVD in which we say a French 8 feeding tube, and with the transfer bag, the blood bag, the empty blood bags. But you have to make sure actually of it's a rough thing, and you put it high if you want to control the pressure, much higher than the head of the bed, or if you want to drain, you put it down low, or if you want to maintain it at the level of the ear, if you want to just have not over draining it. So the other thing that you were asking is that I think the we need to do a sort of a study between the expenses, spending repeated CT scans versus putting in an ICP monitor or an EVD. There should, I don't know, maybe there should be a study comparing those two so that we can see if it's more effective or financially better or economically better, and still be able to achieve that kind of monitoring. Because based on the best strip trial, it says there that although as I mentioned before that there are some things that were pointed out, okay, if your institution has already been able to do the ICP monitoring way before, then versus an institution or a hospital that has been very comfortable or has been able to monitor the patients with just your clinical and also your CT scan CT scan monitoring, then it says there that there should be no change in what you have been practicing if you have found it to be effective to you. But I agree with what you said. There is room for comparing the two. Okay, so we see, especially in low to middle income countries, if these two are as effective, we are able to monitor it, which is actually more advantageous, maybe in terms of financial or economics, pharmacoeconomics, So maybe that all boils down to research. So we need some recommendations with that kind of protocol or guidelines. Okay, so that's one. And when you mentioned cysternotomy versus your EVD, there are those who, cysternotomy. I have heard a lot of lecturers also on how they are saying cysternotomy is better, but again, in the hands of for me, based on the studies, there is not much evidence yet in the countering that the evidence of your EVD, which has been actually incorporated already in the Brain Trauma Foundation guidelines.
Well, thank you very much. We indeed had a wonderful session, and I would like to personally thank Professor Andrew Reisner and Professor Lynn Lucina for this wonderful session. If I may take comments from Professor Shubin.
Okay, thank you for Professor Lucina and for your wonderful presentation. Tonight we have more than 560 audience in the WeChat channel, and thank you, Professor Reisner, and for your very kind word and host the first session. Thank you again.
Well, thank you very much. It is very kind of you to be here, Professor Shubin, as well. So for the next session, I'll hand this over to my co-host, Dr. Libun Singh, who will do the proceedings for me.
Thank you to our first speaker and first chair. And now move on to the second talk by Professor Liao Eugene. And would like give me a great honor to call upon Professor Zubin to chair the second session, Professor.
Okay, I think Professor Dr. Liao Yujing is a very talented neurosurgeon, and he is also a hybrid neurosurgeon, both doing the open surgery and endovascular treatment. He can do he already did a lot of bypass cases independently, and the result is quite good. And so today his topic is measuring the cortical vessels arteries pressure. We all know that in Moyamoya case, after the blood flow going through the Moyamoya vessels, the energy of the blood flow was decreased a lot, and the pressure and the speed of the velocity of the blood flow was all decreased a lot. But how much it was decreased, and how about the real pressure of the cortex vessels? And when we do the bypass and the delta P from the ECA branch, the STA to the recipient artery, the delta P between them is the only driving power for the blood flow going through the ECA to ICA. So now we start to measure this kind of pressure. So I think this is a very important parameters for understand the hemodynamic change of the Moyamoya disease. Okay, now the time is go to Dr. Liao Yujing.
Thank you, Professor Shibing, for your kindly introduction. My name is Liao Yujing. I'm from Shanghai. I'm a student and a colleague of Professor Shibing. And today my topic is pressure measurement of cortical branches in Moyamoya disease. And first of all, let me take a brief introduction of Moyamoya disease. Sorry, my PowerPoint is okay. Moyamoya disease is a kind of chronic cerebrovascular disease and with unknown etiology, and often bilateral will be involved with presented with a steno-occlusive change in bilateral ICA terminal portion. And Moyamoya vessels is a typical findings in cerebral angiogram. And cerebral revascularization is considered to be a recommended treatment for Moyamoya disease, especially STA, MCA, direct bypass is considered as a first-line treatment for adult Moyamoya patient. And as mentioned by our previous publication, there are two types of MCA blood flow direction in the MCA territory, which is antegrade and retrograde. And for the antegrade type, the blood flows from the proximal to distal, despite of steno-occlusive in M1 segment. And from basic hemodynamic principle, we know the caliber pressure of the B point is larger than A point in the left side. But on the right side, it's a case with retrograde blood flow. We can see the MCA territory was perfused by collaterals from ACA and PCA. So the blood flows in an opposite way. So it's reasonable to believe that the pressure in A point is larger than B point. But what is the value of pressure gradient? How do we need to know which pressure is higher, which pressure is lower? And let's take a real case for further understanding. When we open the dura, we can find two or even more options for recipient artery like this patient. A and B is both good for anastomosis, but which one is better? And from angiogram, we know it's antegrade blood flow. So it's reasonable to believe that if we bypass in a point, the delta pressure between the donor and the recipient artery would be larger, and which would provide more blood flow to the brain. Because from the equation of Seizure equation, we know the delta pressure is the only driving force for the blood flow goes to the brain. So for the delta P, the larger, the better. So now let me make a small summary. This is our hypothesis, and we can identify the pressure gradient and the blood flow direction by the DSA angiogram. And after that, we can select a better recipient artery, which could provide a larger delta pressure and which could increase the blood flow and long-term patency rate and decrease complication rate at the same time. But how to prove this? How to prove this hypothesis? And the key is to measure the pressure of the donor, the recipient artery, and this is why we want to measure the cortical branch. But the cortical branch of MCA territory is very small and fragile, so direct puncture or detection is almost impossible. So we developed a set of methods, and we dissect two branches of STA, and one for anastomosis, the other for detection. And the right side is the real surgical field. And after the anastomosis was done, and a micro wire with the detector was inserted into the side branch, into the caliber of the side branch, and we close the end. Now in this closed system, we can measure blood flow from different direction, different routes by close or open different arteries. For example, if we close here and the blood flows retrograde from the MCA to the detector, and which we can measure the pressure of MCA bilaterally. And if we close STA and the proximal MCA, the blood flows from distal to detector, we can measure the pressure of MCA distal side. And in this way, we can measure the pressure from proximal side of recipient artery. And when we close all the outflow channel, we can measure the pressure of STA, and we named it as the PSTA closed. This is final state. All the arteries are open, so this is final state before we close the brain. And we can also close the one direction of the recipient artery. In this way, we can measure the STA to one single direction to recipient artery like this, STA to distal MCA, and this is the STA to proximal MCA, which would give us a further understanding of the pressure gradient distribution in MCA territory. And take a small short look at the detector we used in this method. This is a micro wire with a detector, and it's originally used in coronary heart disease, artery disease, and it can detect the pressure drop caused by stenosis. And for clinical decision to stent or not. And it's got a 3 centimeter soft tip, but in our way, it's usually need to be cut off. And after that, there's a 2 millimeter length detector. And the detector could be connected with this screen on the right side wirelessly. And let's take a real case for example. The left one, upper one is the real surgical field, the anastomosis site here, and the micro wire with detector was inserted into the side branch. And the right one is the recording table, and we can document 7 pressures measured during the operation. And the lower one is what we could see on the screen, and it could provide several information, including the mean pressure of each artery. And the second one is we can see a waveform. There's the systolic pressure and diastolic pressure, and we can also calculate the pulse pressure with these 2 parameters, and the high pressure minus low pressure, we can know the pulse pressure. And it's important to distinguish the characteristics of intracranial or extracranial artery. And this is when we close the STA proximal, and we can measure the pressure of MCA cortical branch. In this case, it's 35 millimeter mercury. And this is an interesting slide. And we can see the upper one is when we close here and here, and the blood flow retrograde to the detector, and the pressure of cortical branch distal side is 27. And the lower one is the proximal MCA, and the pressure is 38. And from this data, firstly, we know it's antegrade blood flow, because if it flows from the proximal here to distal, and which is in accordance with his cerebral angiogram. And the secondary is more interesting. We noticed a higher pulse pressure in proximal side, the lower one, and which means a larger gap between the systolic and diastolic pressure. And this line is more curved way compared with the lower one with a more flat curved way. It's more like intracranial artery. So this detailed information gives us confidence that this kind of method can be reliable, because it's very sensitive to slightly change in the artery. Even in one single MCA cortical branch, the proximal and the distal side, there's 2 different characteristics. And this is the pressure of STA when the distals occluded. It's 80 millimeter mercury. And look at this waveform. It's more like extracranial artery. And when all the channels are open, the pressure goes a little goes down a little bit. It's 74 millimeter mercury. It's in accordance with basic hemodynamic principles. And this is the summary of our case cohort. We now have about 34 cases, and the red data means the blood flows in a retrograde mode, and which was detected in 15 cases, around 44%. And now let's talk about the data. And this is mentioned previously, just to list slightly different between the proximal and distal artery, which make us believe this kind of method is sensitive and the result is reliable. And the second one, this is our main target. And in the beginning, we want to know what is the pressure in cortical branch. Now, this is the first time we know the cortical branch pressure is around 41 millimeter mercury. And we also noticed a small gap between the proximal and distal cortical branch. It's about 4.6 millimeter mercury. And from this small pressure gradient, we noticed there's about 44% cases we can detect a retrograde flow in the MCA territories of these Moyamoya case cohorts. And the retrograde flow is also in accordance with DSA, but in some cases, the blood flow also influenced by the recipient artery site or direction or the vessel networks of MCA territory. And this is also an important result. In this study, we know that in this set of Moyamoya cases, the delta pressure from between the donor and the recipient artery is around 43 millimeters mercury, which is ranging from 14 to 78. And but we still don't know what is the threshold value for good prognosis. So what is the delta pressure would provide a good long-term patency or a good positive remodeling of the bypass or reduce the complication rate, but we still don't know. I think further follow-up or more cases will be needed. And go back to our hypothesis before. And now I think it's utterly proved. Now we are here. Now we know that by pressure gradient distinguishment and carefully recipient artery selection, we can increase the delta pressure between donor and the recipient artery. But whether the increased delta P would increase the blood flow or increase the patency rate and decrease the complication rate at the same time, and what kind of delta pressure is needed, this still need to follow further follow-up and more cases. Now let's come to the conclusions from this study. Two types of pressure gradient in MCA territory in Moyamoya disease was confirmed, and we provide a method for recipient artery selection with only DSA, and we believe it's simple and reasonable. But larger case series and long-term follow-up are needed to describe the correlations between delta pressure and long-term patency and bypass efficacy and the complications rate. And more data needed to know what's the pressure gradient between two vessels, because just mentioned, we can only detect the pressure gradient in one single cortical branch, which is the proximal to distal side. But in some highly selective case, we can perform two bypass, and with the third side branch for the detection. and let's need more cases. Now we are going on. And the last one is this method also got some potential risk of vessel injury, and shorter and softer tip of the micro-wire detector may be needed. Okay, thank you very much.
Okay, thank you, Dr. Liao. And this is our primary results for the pressure measurement of the cortical vessels. And I think Dr. Liao already mentioned that the two different MCA pressure gradient was confirmed, and we already published this article, and we think the mainstream from the donor artery to the recipient artery, if the direction of the blood flow was same as the original blood flow in the recipient artery, that would be a better way. And any questions for Dr. Liao's presentation?
Yeah, thanks, Professor Zubin and Professor Liao. Probably I will start the questioning first before Dr. Ben. I have two questions, Professor Liao. First is, I saw there's a quite a great difference in terms of pressure gradient from your PMCA mean from your donor of your STA. I think it's ranging about 30 to more than 50. In your study, do you find the difference in the pressure gradient detect or predict the outcome in terms of patency of the bypass? Second is the clinical improvement. Third is the cerebral blood flow imaging. Would that the difference give you an idea? What are the optimal pressure gradient difference from the donor to the MCA mean that you would achieve your surgical goal? My second question, Professor, is regarding the angle from your donor to your recipient. By knowing whether it's anterograde or retrograde flow, would that change your decision in terms of angle of the donor to the recipient, how you want to place the bypass? Thank you, Professor.
Thank you, Professor Liu. Both are very good questions. Actually, the first question is I think is the threshold to predict a good result, good long-term patency. Yes, now we are still going on, and primary result suggests maybe a delta pressure more than 40 millimeter mercury would be better. And actually, in most of our cases, and the delta pressure is the larger than 30 millimeter mercury. And in our list case series, the main delta pressure is around 40. So I think the final result may be in this level. And I don't know whether it can answer your question. And the second one, and would you please pardon the second question?
The angle of your donor to your recipient, whether you want to angle towards the distal or angle towards the proximal, would that change the difference by looking at pressure?
I also thinking about that. Yes, it's once we identified the blood flow direction in the recipient artery, we can try to make the donor and the recipient artery flows in the same direction. Yes, it's also helpful. I think it can reduce the energy loss and reduce the blood flow competition, and which may reduce the post-operative transient neurological deficit. And it's reasonable to believe that in this way, it can make sure a good long-term patency and good for the the positive remodeling of the bypass. And we also publicate this article about the blood flow direction of the donor artery and recipient artery. Thank you.
Thank you, Professor Liao. Dr. Ben, you may ask your question.
Yes, thank you so much. Thank you so much, Dr. for your question. I have the same question as the Dr. Liu that Dr. just asked about the direction of the fish mouth. So, may I confirm that to you? My first question is, may I confirm that to you, based on your preoperative DSA, that you classify into antegrade or retrograde flow, and then you design the direction of the fish mouth either is towards or away from the proximal end of the recipient artery, meaning that the antegrade flow or retrograde flow has a different has a mirror image of the fish mouth and the thermosis. And also, my second question is, have you tried to compare your data with the preoperative DSA flow study? Is there any preliminary results? And whether these two studies can be correlated? And finally, really a great study, and really appreciate your effort on it. Congratulations to your team about this study.
Thank you. Thank you for the question. First question, in my opinion, I think if we can make the donor and the recipient artery in sync direction, it's better. But sometimes it's difficult or even impossible because the direction or the site of the recipient is not so easy for the other way, in the opposite way, the anastomosis. I think the delta pressure is more important because in our case series, we noticed around a mean delta pressure of about 40 millimeter mercury. And I think this kind of delta pressure is enough to maintain patency, even reverse the blood flow in the recipient artery. And that's my answer to your first question.
Yes.
And your last question about compare with this result with what? I beg your pardon.
To the DSA flow study, the DSA to your whether it correlates with your the intraoperative results, the DSA. Have you tried to do some flow study on the DSA?
You mean in hybrid operation room in the thing when in the operation? No, no so far. But we
yes, Dr. Ben. Actually, we are now use special DSA sequencing to analyze the blood flow pre-operatively and post-operatively. Yes, every second we have about 15 frames of the angiogram. That's much frequency than the normal angiogram to get more information of the blood flow. But after the Moyamoya vessel network, the contrast normally diluted a lot. So the distal network of the vessel normally couldn't shoot very satisfiedly. Yeah, that's also some problem. So yes, but we are trying to get more information from the preoperative DSA.
Yes, your answer solved my query, because I agree that the more lack affect the DSA findings and also process. Just final confirmation. May I ask, do you also measure the STA stomach pressure and in your study?
I beg your pardon.
The STA pressure, you measure it as well in your study, right?
Our STA pressure normally same as the artery monitoring, like the extremities, like hands and yes, the radial arteries, almost the same. Yes.
I see.
And
okay.
Dr. Liao already mentioned that we think too low of the delta P or too high of the delta P was not a very good sign for the long term or some neurological deficit. If it's too high, maybe it can cause a hemorrhage.
Yes.
If it's too low, maybe the blood flow was not so good. But we are still collecting the data and to analyze it.
Yes, because I think your study is very, very important. That if you can correlate the intra finding with the preoperative DSA results, and then you could try to design the diameter of your fish mouth before the operation. I think that's quite
actually we don't do fish mouths very often. We my suggestion is the oval shape anastomosis. Yes, it's mimic the nature branches.
I see. Yes.
Fish mouths can make the the stoma much larger, but that's not good in hemodynamic theories.
I see. Yeah. Thank you so much. Thank you so much, Professor.
Professor Sude, who is also a cerebral vascular surgeon. Professor, may you give your comment or question?
Hello, Dr. Zubin, and your team is doing quite wonderful work on Moyamoya, especially in the pressure measurement. Just one comment and one query. The comment is that you have presented the case of Moyamoya in which you have done the STA-MCA bypass and the pressure measurement. In order to know the normal physiology and normal pressure gradient, do you have an experience with doing STA-MCA bypass for other indications in which you have done a pressure measurement, so that you understand what is a normal gradient in patients with non-Moyamoya cases, and then you can compare with Moyamoya cases the pressure gradient? And the second question is,
actually, sorry, I think we can answer your first question. Actually, we also measure the pressure gradient, like we also did some bypass in the ENT, the combined with the ENT doctors, we treat the nasopharyngeal carcinoma to do the double bypass and occlude the ICA, which was already involved by the carcinoma tissue, and we have to sacrifice this ICA, and then we will close the ICA, and we also measure the delta P.
Okay.
And also some in different, even in the giant aneurysm case, we also measure the different of the pressure delta P. Yeah.
Okay, and you also mentioned that you would be deciding preoperatively based on the angiograms, which will be your donor vessel and your recipient vessel. So that I have seen that you have done very customized STA-MCA bypasses for patients. Is this decision actually influenced by the presence of infarcts that are already established, particularly in Moyamoya cases? Patients will already have established cortical infarcts. And also the presence of cortical infarcts can actually alter your pressure recordings. If you have a distal cortical infarct, the distal pressure must be quite low compared to the proximal pressure. And also, as you said, the collateralization can definitely influence the distal pressures. In some of your cases, you have a higher distal pressure. So, but what about the case of distal infarcts? If you have infarcts in the distal territory, you can have a very low pressure in the distal cortical branches compared to the proximal stump. So in that case, what's your opinion? We are unable to hear you, sir.
Yeah. Sorry. I think your question is very important. Actually, we not normally worry about the pressure gradient from the donor artery to the recipient artery. Normally, I worried about the pressure change in the vein, which drain the naval corticals. You know, after the bypass, actually the veins pressure would also change a lot, and sometimes maybe even I think it's possible to even higher than the navel feeding arteries. So that kind of condition also can cause infarction. So now we are trying to measure the veins pressure, and so this is our only our primary results for the arteries measurement. And after that, we will try to measure the veins pressure change. Yes, that's my hypothesis for the navel cortex infarction. Yeah, that's more. I think the veins pressure change is also extremely important.
Do you base your decisions on surgery, where to do the bypass, based on MR perfusion images?
Yes, that's very complicated decision making, and we did a lot of this kind of study work, and I already published one book, but it's in Chinese. And if you are interested, maybe we will translate it into English later.
Very definitely interested in reading an English version of it.
Yeah, but it's too difficult to explain in a very short answer. Yeah.
Thank you.
Okay.
Thank you, Professor Sude. Dr. Kasanov, do you have any question from your side?
So I'm not well experienced in the cerebrovascular, especially for Moyamoya disease. So I don't think that I can make any comment because I'm not experienced in these fields and I'm still learning this one. So I want to thank Dr. Professor Lucina for excellent presentation, because traumatic brain injuries, it's the most common in Uzbekistan, and we have to deal every case on daily basis. So I got many points, I make notes, and I think it will be in my daily practice, because we have to deal with at least one case a day, maybe. So this was more important point, and especially for Moyamoya disease, we are also implementing some kind of bypass procedures, and it's becoming popular in Uzbekistan, and even we had some successful cases. So I think it still needs some improvement and study, and it will improve day by day, case by case, I think. Thank you for you all.
Thank you, Professor Dr. Kasanov.
Thank you. Thank you.
Professor Resner and Dr. Professor Lin, do you want to ask any question to Professor Liao?
Yeah, I think the surgery for Moyamoya, the bypass surgery here is also starting with here in the Philippines. We have open vascular neurosurgeons who have trained also in, I think some of them trained in Korea. So that is a very interesting point that you guys have been doing, you know, the angulation and the pressure that you have been measuring. So, but your paper is published in Chinese. So, also, I think I've heard that you have performed a lot of procedures already, and I hope we would be very interested to be able to read some of those papers from your publications. So thank you so much for your presentation.
Thank you very much for an excellent talk. As you alluded to, we do deal with Moyamoya phenomenon, Moyamoya disease in children, and especially where I live in the southern part of the United States, we have a high incidence of sickle cell disease. And these children are prone to, among other things, develop quite significant Moyamoya phenomenon. I've operated on some of them. I have not done measurements that you have recommended, but would certainly give it some thought. My only comment is, even if the sickle cell is well controlled with transfusions, generally these children do a lot worse than de novo and do not respond to surgery as well as those that have Moyamoya of unknown etiology, or Moyamoya disease per se. So just a comment. And maybe that speaks to the disease generally, where not only do you have to treat the neurovascular component, but the overall disease as well, which is going to affect the whole body.
Yes, thank you, Professor Resna. Actually, you mentioned the sickle's disease, and I also have a Italian patient also have the sickle's disease, and they consulted me, and I recommended the EDMS, just like Dr. Casanova mentioned in Tajikistan, Dr. performed, and the result is quite good. And after the treatment, the ECA branch making a lot of spontaneous stoma to the cortex. Yes, it's also effective.
Very good.
Thank you.
Thank you. Very interesting discussion.
Okay.
Yeah, may we now listen the concluding remark from Professor Zubin, Professor?
Okay, thank you, both speakers and the moderator, Professor Resna. And today is a very successful webinar, and until now we have more than 600 audience in the WeChat channel, and thank you again.
Thank you, Professor Zubin. So we're going to end our webinar series today. It's a great honor for all of us to have two great lectures. And on behalf of the Education Committee of the ACNS and the President, Professor Yukato, I would like to thank both speakers of today, Professor Lin Lourdes Lucena and Professor Liao Yu-jun, as well as our chairs, Professor Andrew Resner and also Professor Zubin, for the time and support for the ACNS webinar. I would like also express my sincere gratitude to Professor Zubin again for broadcasting this webinar on WeChat channel. And a special thank to all panelists, namely Professor Sudel, Professor Dr. Kasanov, Dr. Ben, and all audiences who join us today. So until we meet again next Saturday, it's bye-bye from all of us. Thank you very much for joining. Thank you, Professor.